Hello, my name's Lucy. I work with the Hampshire Eating Disorder team, and today I'm going to talk about eating disorders alongside my colleague Nicola Aldrieve. So why do eating disorders develop? There are often lots of contributing factors to why an eating disorder develops, and very rarely one single cause. The contributing factors would be genetic, biological, psychological, social and environmental. So there is some research that suggests that if a young person develops an eating disorder, there may be a genetic link within the family system. From a psychological perspective, the young person may be particularly anxious, have low self-esteem or perfectionistic traits. Social and environmental contributing factors could be bullying, exposure to social media, and being in a peer group where weight and shape is highly valued. From a biological perspective, there may be differences in recognising hunger cues or experiencing taste. So there are a number of types of eating disorders: anorexia, bulimia, binge eating disorder, OSFED and ARFED. In terms of anorexia, it's often the most recognisable eating disorder due to the considerable impact on somebody's physical health. Often by the time it's recognised, a young person could have been struggling with eating difficulties for a while. Anorexia is a restrictive eating disorder whereby somebody will restrict the amount of food that they eat in order to influence their shape or weight. Often by the time a young person is physically underweight, they will have been struggling with eating difficulties for a little while. Bulimia nervosa is whereby somebody will induce vomiting as a way of managing their weight or shape concerns. Binge eating disorder is a disorder whereby somebody will eat an excessive amount of food in a way that feels uncontrollable and can quite often impact on well-being. OSFED is a diagnosis whereby they may have many traits of an eating disorder, but they might not quite meet the diagnostic criteria. And ARFED is a diagnosis that my colleague Nicola will talk about in more detail later on in the presentation. Some people will experience disordered eating. This is not a diagnosis but a descriptive term of behaviours. This can occur when somebody uses food or their weight or shape to manage difficult emotions. It's important that we understand what the driver to the behaviour is in order to ensure that young people are accessing the appropriate treatment. When doing an assessment for eating disorders, we would be looking at 3 different areas. Behavioural, so has there been a change in eating habits? Has the young person become particularly secretive? Have they been hiding food or avoiding certain food groups? Has there been an increase in exercise? Has there been any evidence of vomiting, using laxatives or diuretics? Has the school or social functioning altered? So have they started to really struggle at school whereby before they were okay? Have they stopped wanting to go out with friends? Has their habits and interests changed? Have they become more focused around food? Have they changed the types of clothes they wear? Often young people with a restrictive illness will hide the fact that they've lost weight by wearing baggy clothes. With eating disorders, sometimes people can develop obsessional behaviours. This can be around checking, it can be around body checking, it can be around hand washing as a way of managing the anxiety that they're experiencing. From a psychological perspective, there may be a preoccupation with body image, food, dieting and exercise. The young person may talk a lot about different foods, may talk a lot about perhaps baking or particular diets that they've read about on the internet. The young person may develop a fear of weight gain. There may also be a change in mood. The young person might be initially happier because they feel like they're in control of an element of their life, but over time may become low in mood and more withdrawn as the thoughts preoccupy their mind. There may be other mental health issues that develop, such as anxiety, irritability and obsessional behaviours. Often young people develop a high interest in food preparation and the calorific information on different foods, and will often question how meals are being prepared and what ingredients are being used. And young people may also develop poor concentration due to the lack of nourishment and also the preoccupation with thoughts around weight, shape and body image. From a physical perspective, We may expect to see a weight loss or lack of expected weight gain. Often young people can experience fainting or dizziness. At times they will appear cold and weak with a significant loss of energy. Their sleep may be interrupted. In girls, we may see a loss of periods. In boys and girls, there may be issues with constipation or digestive concerns. We may also see hair thinning, Lango hair, which is a thin layer of dark hair that covers the backs of the arms and the back. And we may also see calluses on people's hands or difficulty in cuts and bruises healing, as we would expect. Talking to a young person where you suspect that they might be struggling with their eating may always be a challenging conversation. However, we recommend that a calm, curious, and non-judgmental approach is used. Talking to a young person about whether they have an ideal weight in mind, whether they're actively trying to lose weight, if they're avoiding certain foods, have they increased their exercise, have they tried anything else to lose weight, such as vomiting or using laxatives, have they noticed any physical symptoms, so things like chest pains, dizziness, feeling really weak or trouble sleeping. A really important question to ask is also, have they experienced any thoughts around suicide or any experiences of self-harm? So when we think about next steps, it's really important to gather as much information as possible. Quite often young people are part of groups such as guides or brownies, and it may be that their leaders have noticed changes in their behaviours. Schools are also a really important source of information, and there may be other important adults that are involved in your young person's life that may be able to give you further information about what they've noticed. It's really important to visit your GP for further guidance, and your GP can offer a physical assessment to ensure that the young person is safe. Often referrals are made to our team by a GP, and this is important because they are able to offer the physical information that we need to ensure that we are able to offer a timely assessment. Physical health is not the only factor when we are assessing whether a young person is suitable for our team, but it is an important factor, and having the right information is key to this. So some of the information that's really important to help assess a referral when sent to our team is information around the rate of weight loss, how quickly has a young person lost weight, what their pulse is, whether their heart rate is too fast or too slow, any dizziness or change in their blood pressure, their temperature, any difficulties with fluid restriction or dehydration, the level of food restriction, so how many calories is somebody eating a day, whether or not they're binging, and whether there's any biochemical abnormalities, and this would be identified via a blood test, and if the young person is purging, so if they're using laxatives or if they're vomiting after they've eaten. When a referral is received into our team, a member of our duty triage team will contact the family for further information. At this point, a decision will be made as to whether or not an assessment is going to be helpful. If it's felt the assessment wouldn't be helpful, we would look to signpost the family to information that would be. Following the duty triage process, if a young person is accepted for an assessment, we aim for this to be within 4 weeks. If it's felt, however, that the young person needs an urgent assessment, we aim for this to be within a week. The first line intervention for young people that have a diagnosis of an eating disorder is FTAN. This is a model whereby the family assists the young person to recover from the eating disorder. In clinical trials, 2/3 recovered by the end of treatment, and in follow-up, between 75 and 95 were fully recovered at 5 years. The aim of this treatment is to avoid hospital admissions and for the young person to be able to recover within their home environment. A young person who is experiencing an eating disorder will need a different parenting approach to support them towards recovery. When we work with families in clinic, we talk about different carer reactions and different carer emotions, and this allows us to develop a shared language. The kangaroo reaction is whereby the parent takes over and tries to make everything right. The rhinoceros is quite authoritarian. They use logic to try and win the day and make everything a bit better. And what we try and coach parents towards is being able to use a dolphin approach, which is calm and consistent, coming alongside their young person, being boundaried in their expectations, but also supportive. When we work with families, we often notice different carer emotions. We can think about these in terms of an ostrich, whereby a parent or carer will avoid the situation and avoid the intensity of the emotions that often arise. It could be the jellyfish, where there's too much emotion in the home and too little control. What we would coach families to move towards is a St. Bernard, so just enough compassion but consistency to ensure the young person feels safe but heard and cared for. Eating disorders are often long-term conditions. There are some factors that maintain an eating disorder, and these include social isolation, comorbidity, so anxiety or depression, body image disturbance, cognitive difficulties such as poor concentration, rigid thinking and memory problems, or neurodiversity such as autism. Please remember that eating disorders are nobody's fault. Nobody has caused an eating disorder. It's an illness, the same as any other illness. The family and carers are the greatest resource for a young person's recovery from an eating disorder. Physical health recovery occurs more quickly than psychological recovery. Psychological recovery can take a long time. Health and happiness needs to be prioritised. There may be times when a young person is too unwell to attend school, but we would always work with the family and the young person to ensure that they're able to access education as soon as possible. Eating disorders are very, very challenging, and it's important that carers seek as much support for themselves as well as their young person as they can. Take things one day at a time, try to stay calm, and work as a team where possible to wear down the illness. Be consistent and clear as well as boundaried in your expectations. Take more active responsibility at meal times in terms of preparing food, planning menus and serving the food for the young person. Avoid buying diet, low-fat or fat-free foods. Where possible, eat as a family because this role models normal behaviour. Plan non-problem focused talk for meal times. Plan distractions for the young person. Distractions post-meal for a young person can be really important. So things that they enjoy, maybe watching something on TV or playing a game with a sibling can be really helpful. And try to think about motivators with your young person. So what can they do as they move through their recovery, whether that's increased activity or seeing more friends or getting back to school.
Hello everyone, as Lucy said, my name's Nicola. I'm one of the occupational therapists in the eating disorders team, and I'm going to be talking about ARFID. ARFID stands for Avoidant Restrictive Food Intake Disorder. It still feels like a fairly new diagnosis, although it's been in the DSM-5 since 2013. So what is ARFID? ARFID is a feeding and eating disorder. In order to be diagnosed with ARFID, we would expect to see a significant weight loss or faltering growth or development, a significant nutritional deficiency, a dependence on enteral feeding or oral supplementation, and a marked interference with psychosocial function. When we talk about ARFID, we often talk about the drivers that young people can experience, and those are three drivers of sensory sensitivities, lack of interest, or a fear of aversive consequences. When somebody has a sensory sensitivity, they may struggle with trying different brands of foods or being around foods that are new to them. They might not be able to tolerate being in the same room as a new food. With lack of interest, a young person might not receive the same cues, the same hunger cues or thirst cues as others. And it's just not something, food and eating isn't something that would necessarily come into their mind to remember to be able to eat. For fear of aversive consequences, a young person might have experienced a specific trauma related to food and eating. So it might be due to a choking episode or a sickness bug, for example, that then means they find it very, very difficult to start eating again. It's important to say that young people that are autistic can also have a diagnosis of ARFID. With autism, we would expect there to be some challenges with food and eating and some challenges around food and eating in public. Where we would consider an ARFID diagnosis would be if that young person also has a nutritional deficiency or we're concerned about their physical health. So ARFID is very different to fussy or picky eating. So we will all have strong preferences and likes and dislikes of food, which is absolutely normal and appropriate. It's also completely normal for a child to eat less or more in response to feeling anxious or overwhelmed or even feeling happy. Where ARFID is different is it's a pervasive and chronic difficulty which causes a significant impact on health, development and functioning in everyday life. So these are some signs and symptoms of what it might look like if a young person has ARFID. So they might be underweight, they could be average weight or overweight. Generally, they will have an extremely limited selection of foods, so they may only be able to eat less than 10 to 15 different types of foods, or it might be particular brands of foods. Young people with ARFID may also stop eating or drinking altogether. Generally, there's an impact on family functioning and dynamics. Young people that have ARFID may really struggle to be able to eat with their family at meal times, and so quite often that can be distressing for the family. Young people that have ARFID often present very young. These difficulties may have been present since weaning, so it may have been going on for quite a number of years. They may rarely appear to be hungry or ask for food, and they may avoid or refuse to eat or need particular distractions in order to be able to eat. They could also gag or vomit when they're trying to eat new foods, and generally there's a very high anxiety over new foods. As with any of these things, there's often not a single cause for something like ARFID to develop. Some of the risk factors that we would consider would be a premature birth or complex medical issues in early life, early feeding difficulties, so difficulties latching on during breastfeeding, vomiting or gastric reflux as an infant, severe constipation or eczema or food allergies, a later introduction of solid foods, likewise sometimes an earlier introduction of solid foods, developmental difficulties or delay, a general dislike of change or anything new, or lots of anxiety within the family. So if you're concerned that a young person may have ARFID, take the following steps. It's really important to have a conversation with the young person and their primary caregiver. So understand what's causing the difficulties with eating. Is it around those drivers that we discussed earlier, or is there something else going on? Seek consent to share information with the relevant people, whether that's with the GP or whether that's us in CAMHS, and seek consultation and advice from ED service providers. We would ask that people are mindful of any safeguarding concerns around food and eating. What we wouldn't consider to be an ARFID diagnosis would be if a young person isn't able to access the food and fluid that they need, or if there's challenges around boundaries or expectations at home. When a young person comes for an ARFID assessment, they will meet with a healthcare professional in the team who has specialist knowledge of the condition. Prior to the assessment, we ask for young people and their carers to complete different questionnaires and give us different pieces of information in order to understand whether they may meet diagnostic threshold for ARFID. We would ask for a food diary to be completed, and we also complete a pre-assessment questionnaire. Where possible, we would also ask a young person has nutritional bloods completed, although we recognise that for some young people this is too difficult and it's not always something that we're able to do. So therefore we would ask for a longer food diary to make sure that we can analyse their nutrition appropriately. It's really important that the child attends their assessment, even if they're only little, so we can understand and hear from them what their experience is. So some general tips about ARFID. Feeding difficulties are usually long-standing and are really difficult to change. We would ask that people avoid force feeding, having long gaps between meals to try and evoke hunger, or withholding preferred or safe foods. For a young person that has an ARFID diagnosis, this won't work, and the risk is that they may stop eating. Likewise, reward systems will not always be beneficial for a young person with ARFID. This is because they're not motivated by food, and it adds more pressure to them being able to eat. We would ask that young people who have a ARFID diagnosis are allowed to eat their safe foods at school. This might be challenging, as for a young person with ARFID, their safe foods could be those which are beige type diet, like crisps or chocolate or chicken nuggets, for example. It's important that parents and caregivers are mindful of contamination fears and that they aren't enforced for those with ARFID. I can't stress enough how important it is to not overly worry about healthy eating. We live in a time where we're reminded constantly about what's healthy, what's unhealthy, and the dangers of processed food. But sometimes for young people that have an ARFID diagnosis, it's those processed foods that are allowing and enabling them to continue to grow and develop as they need to. And that might be what they need right now. So some tips for managing sensory sensitivity could be, during the meal, aim to reduce sensory stimuli. This might be through having a familiar or a predictable mealtime routine, allowing the child to eat on their own if they need to, especially if they seem anxious or overwhelmed. Reduce background noise where you can and avoid bright lighting. You can also think about making sure the young person has a comfortable and supportive place to eat at meal times. Ensure the dining table is free of clutter and have one food on the plate at a time. For some young people, it can be beneficial that they have something heavy on their lap when they're eating, because that helps them to feel more regulated and helps with them moving from a fight-flight response to a rest and digest place. Any new foods or smells should be introduced very gradually. It might be that the young person starts by working on being able to tolerate being in the same room as a new food before they're able to get to a point where they can touch the food or even put it near their mouth. And this process could take weeks or months to get to that position. Stressful periods should be avoided when making any changes. So for example, it might be Christmas or start of a new school term, or even something like moving house. If the young person feels anxious or overwhelmed at meal times, then gentle distraction can be helpful. But think about whether you're using something which could be overstimulating. So some tips for managing lack of interest are as follows. Routine is often the most important strategy for a young person with ARFID that experiences lack of interest as one of their drivers. We would ask that food and fluids are offered regularly and at predictable times throughout the day. External reminders can often be helpful, particularly for older adolescents. So it might be that they have a timer on their phone that tells them when they need to have something to eat or something to drink. Consider the division of responsibility. What this means is it's a parent or carer's responsibility to make sure that the child has food available and is offered that food and drink to eat. But it's the child's responsibility in deciding whether or not they're able to eat that food. Make mealtimes fun and social where you can, and role model to the child your own eating pattern. So make sure that you also eat and drink regularly throughout the day. Role modelling is also very important for managing aversive consequences. Show that the food is safe and it's okay to eat. Regular exposure to safe foods can be helpful, and always give positive feedback and praise when the child manages something that's been very difficult for them. So some things to remember. Feeding difficulties are usually long-standing, and change or progress can be slow and limited, but changes are possible with clear expectations and boundaries, a consistency in approach, structure and routine, perseverance and commitment, and motivation to make changes. It's important that you set family rules around eating behaviour. For example, we all have breakfast. This might mean that the family system needs to change around the young person that has an ARFID diagnosis. Within the team, we talk a lot about approaching food as medicine. It's a prescription in order to get better. We don't have to love or enjoy the food we eat, but we do have to tolerate it for our well-being and our functioning. As Lucy's already said, depending on the risk of physical health compromise, we might need to reduce or limit activities if nutrition is inadequate. So the example given here is that you can't take driving lessons unless you're eating regularly, as it might not be safe for you or other drivers if you haven't eaten and you get behind the wheel of the car. Within the ARFID pathway, we recognise how difficult it can be for young people to go back to school if we have to reduce it. So wherever possible, we do try to avoid that unless we are really concerned about physical health. It's important that parents and carers can also role model trying new things. Stepping outside of your own comfort zone and embracing change in a positive manner can also be helpful. If changes are desired and needed, then changes in mindset, attitude and behaviour are required from all family members, not just the young person that has ARFID. Consistency of approach and messages between caregivers is crucial. So for example, in respect of boundaries, expectations, rules, etc. Parenting a child with ARFID can be absolutely exhausting. And it's easy to fall into a habit of only offering preferred foods. It's also okay to only offer preferred foods. If a young person is not motivated to change and they're physically good enough, then that's okay. Now might not be the time to offer new foods to them. If the young person is ready to make that change and wants to be able to try new foods or needs to because of their nutrition, then it takes perseverance and commitment by the young person and their caregivers to persist in making changes and doing something different. And it might be that you need to try several times a day, every day for a prolonged period of time in order to make a sustained change. Change is scary, it's uncomfortable and it's often not enjoyable. Young people might lose sight on why change is necessary or important, so adult caregivers need to remain positive, hopeful and encouraging. We all need a reason to do something or to not do something. And everybody's goals and motivational reasons will be different. And that's the same for young people and their parents. So parents might be motivated by frustration or concern and worry about what their child is eating and wanting to know that they're physically good enough and they're going to be well. Whereas a child might not share these concerns and therefore won't be driven and won't have the same motivating factors as their parents do to help them work towards change. Within the team, and when we think about motivation, we talk about push factors or pull factors. A push factor might be something that helps us to move away from a position. So the example given here is that my hair's falling out because nutritionally I'm compromised. I don't want that to happen, and so therefore I'm going to make some changes to stop this. A pull factor is something that helps us to move towards a position. So for example, I want a boy or a girlfriend, and I want to be able to go out for dinner. I can't do that at the moment, so I'm going to make changes so that I can go to a restaurant with my partner. Quite often in the team, we don't see young people experiencing real motivation to change, generally until they hit their adolescent phase, when their peer relationships become most important to them, and they're driven by wanting to do the same thing as their friends do. There is a real timing element to any change work. A young person has to have internal, personal reasons in order for them to make changes, for them to be able to engage in the process fully and to be able to make sustained change. Here are some resources that can be helpful. Firstly, the Hampshire CAMHS website. There's a wealth of information on here. There's lots of information about eating disorders and ARFID, but also information on other comorbidities such as anxiety, low mood or self-esteem. There's also the BEAT website, which again gives lots of information on the eating disorders which we've covered today, and also some information around ARFID. The Child Feeding Guide is an accessible website that can talk to you about the steps to eating, which I've touched on. The first book on the list, Food Refusal and Avoidant Eating in Children, is something which is very accessible for parents and carers, and it's written by Dr. Gillian Harris and Elizabeth Shear. Avoidant Restrictive Food Intake Disorder, a guide for parents and carers, is written by Rachel Bryant-Moore, who is one of the leading voices in the development of the ARFID diagnosis. And lastly, Helping Children Develop a Positive Relationship with Food by Jo Cormack. The Hampshire Eating Disorder team has 3 hubs across Hampshire, one in the north of the county, one in the south and one in the southeast. We are a multidisciplinary team and made up of nurses and support workers, a paediatric liaison team, medics, dietitian, systemic therapists and family therapists, psychologists and occupational therapists. Lucy and I hope that this video has been helpful for you. As well as the resources that we've discussed, you can also find out more on the Hampshire CAMHS website.